Good evening, everyone, and thank you for joining us. Before we get started, I just want to share a few brief housekeeping announcements. First, we would like to thank everyone who submitted questions in advance of tonight's town hall. We hope to address many of your monkeypox questions over the next hour with our panelists. And again, if you have additional questions or need clarification, please use the Q&A function in Zoom. And as a reminder, this is a public forum, so anything that you type will be visible to others. Tonight's town hall is being recorded and streamed on the county's social media platforms. And please feel free to share those links so that others can tune in. And finally, a recording of tonight's event will be available on the Montgomery County YouTube page, and we will also send that link out to everyone who's registered tonight once that video is uploaded. And now I'm pleased to turn it over to our moderator, Dr. Lorraine, to start us off.
Thank you very much, Kelly. And I'd like to welcome everyone tonight to our town hall on monkeypox. This is a format that we have developed and used, I think, quite effectively for communicating about COVID and COVID vaccines in particular. This is the point now where we have another public health emergency, that of monkeypox. And there's a lot of information that we would like to get out to the public, and people are very, very interested in hearing about it. So we're glad that you've joined us tonight to be able to share this information with you. And we've assembled an excellent panel that will be able to answer your questions. And I'll be introducing them at this point. Dr. Lisa Spacek is the CMO, Chief Medical Officer for Novus Medical Services. Dr. John Russell, who is the chair of the Department of Family Medicine at Abington Jefferson Health, and Dr. Lawrence Livernace, who is the chairman of the Department of Medicine and an infectious disease specialist with Mainline Health. I will be serving as your moderator this evening. I am Dr. Richard Lorraine. I am the medical director of the Montgomery County Office of Public Health. I'm an internist, and I've been practicing in Montgomery County for about 37 years now. I've been the medical director of the Office of Public Health for the last 6 years. In addition to clinical practice and the Office of Public Health, I am also commissioned in the New Jersey Air National Guard, and I currently command the 108th Medical Group. And I will turn it over to Dr. Lisa Spacek.
Hi, my name is Lisa Spacek. I'm a subspecialist in infectious diseases, and I am boarded in both internal medicine and infectious diseases. My PhD is in public health, and I serve as the Chief Medical Officer for Novus. We have 5 settings in the counties around Philadelphia, and we take care specifically of the LGBTQ community, and we've been very involved in testing, treating, and vaccinating for monkeypox.
Thank you, Dr. Spacek. Dr. Russell.
I'm John Russell, longtime resident of Montgomery County. I am the chair of family medicine at Abington Hospital. I head the family medicine residency program, wear a lot of hats at Abington. I'm kind of the vaccine expert for the hospital. I chair the pharmacy committee, chair the bioethics committee.
Thank you, Dr. Russell. And Dr. Livernace.
Good evening, I'm Larry Livernace. I'm a board certified infectious disease physician, also board certified internal medicine. I've been in clinical practice in infectious diseases at Lancaster Medical Center for the past 30 plus years. And for the past 10 years, I've served as the chairman of medicine for the Mainline Health System.
Thank you, Dr. Livernace. The format for this evening is that we will be dealing with questions that have been submitted ahead of time. And each of our panelists will take turns in answering these questions. That will go on for approximately 40 minutes. At that point, when we have completed the pre-submitted questions, we will also be answering any questions that might have come in during this evening's session. So if you have those questions that come up, please feel free to type them into the Q&A, and we will be taking those when we've completed the pre-submitted questions. And having said that, we will start off with Dr. Livernace. I want to ask him, since we're talking about monkeypox, well, what exactly is monkeypox? And are there different types of monkeypox? How deadly or how serious is monkeypox?
So monkeypox is an infection that's caused by a virus. This virus comes from a family of viruses known as the orthopox viruses. I think that's an important point. Smallpox and cowpox are also part of that group, and you'll hear more about that, I think, as we go on in the evening. It's not new. It was first identified in the 1950s in monkeys, and in the 1970s, the first human infections were seen. And it's been an ongoing problem for 10 years or more in various countries in Africa. In 2003, it actually caused an outbreak in the United States when rodents from Africa came here and infected prairie dogs that people were keeping as pets, and those individuals became infected. I would say the name can be a little confusing, and I'd like to point out, although we call it monkeypox, it was first discovered in monkeys, but it's probably much more prevalent in rodents and other small mammals in Africa, although we don't actually know where the true reservoir of this virus exists. We know it is seen in those particular animals. And although it's called a pox virus, and that refers to the skin lesions, it's different than some other pox viruses. And the one I'd like to point out in particular is chickenpox. There's no relationship between chickenpox and monkeypox, but cowpox and smallpox are close relatives of it. There are actually two different strains of monkeypox. The West African strain is the one that's causing the worldwide outbreak, and the one that's in the United States right now. And that's important to us because that's the less deadly form of monkeypox. And textbooks and others would tell us that the mortality, the death rate is about 1% in monkeypox. But I would point out most of that data comes from Africa. And in the United States now, we've had about 18,000 cases. And I think yesterday was the first reported death. And we saw a similar thing with Ebola. You'll remember in Ebola, this highly deadly virus in Africa, we thought the death rate was as high as 70%. In the United States, we didn't have that many cases, but nobody died from Ebola. So the death rate in the developing world may be different than what we've seen in Africa.
Sorry, forgot to unmute myself. Thank you, Dr. Libanese. Dr. Russell, next question. What exactly are the symptoms of monkeypox? And what is the timeline from when you come in contact with the virus to the time when you see symptoms? And I would also add to that, what is the timeline for the illness itself, for the final resolution, and when someone might no longer be considered contagious?
Terrific. So people are going to start out with a little bit of a prodrome. So someone is going to be exposed to this. Can vary anywhere from 5 to 21 days, but usually in that 7 to 14 days. So someone might start out with a little bit of a sore throat, really might not notice anything, then moving to having a fever and some swollen lymph nodes, some adenopathy, and at that point might be developing some skin lesions. With the pox viruses, when we think about smallpox, and we heard about smallpox, but smallpox eliminated from the planet in 1977. Smallpox lesions all lived at the same stage at the same time. Heard about chickenpox. Chickenpox lives, if you remember when you had chickenpox, your kids had chickenpox, they might live at different stages at the same time. So you're going to have these lesions that are all going to be in the same stage. A lot of people are very asymptomatic with that. You certainly can read cases of people, especially people who have some lesions in their genital area, for them being very painful. And then the course of how long it takes, it's about 3 to 4 weeks before this evolution. And certainly there are lots of pictures online that you can see the evolution as these lesions kind of look like different things. And in the beginning, they might look like some bug bites. They really are fairly innocuous, and as they kind of go through their stages. But someone who has monkeypox, 3 to 4 weeks might be the timeline that someone is out of work, not necessarily sick, and but someone who is potentially contagious, who shouldn't be back at work. So hopefully it's a mild thing. I think the term and a lot of the hype has people a lot more fearful. And I think really good public health and good information is going to be a big part to really conquering this Montgomery County, Pennsylvania, and the whole United States.
Thank you, Dr. Russell. Dr. Spacek, something that people really, really are interested in hearing about. How does monkeypox spread?
Thank you for the question. Monkeypox is spread by contact. The contact would have to be close and intimate. So one of the questions that has come up is this or isn't this a sexually transmitted disease? I think the way to best say it is that it's sexually transmissible in that it happens in close and intimate contact. So in those settings of close intimate contact where people are skin to skin touching for a period of time is the best way to transmit monkeypox. And that's what we're seeing in the US. Other ways to think about the spread of monkeypox is in what we call fomites or objects. And the best example of that is if a patient with multiple lesions or has the monkeypox infection is in bed and the bed sheets can harbor, the bed sheets can have the viable virus that then could be transmitted to someone else in the case of sharing a bed or co-sleeping. So the idea that this is an intimate contact related transmission is really important, but it's not like COVID in that it's not aerosolized, and we're not seeing the infection getting into the general population. So really what we're seeing in the United States is that this is a contact transmitted disease in specific populations. And as an example, in the United States, the vast majority of people who've been infected with HIV happen to be men and men who have sex with men. And this is really speaking to the fact that it's a close contact, not airborne. It can be spread by respiratory droplet, but it's not like it's hanging in the air like we know COVID does. So with respect to this transmission, the issue of whether or not it's sexually transmitted, it is sexually transmitted, but we're staying away from calling it a sexually transmitted disease because that's not the only way that it can be transmitted. So we're saying it's sexually transmissible in the way that one person can give it to another. I do like to point out that we aren't seeing it in the general population, and that's different from what has been seen in other parts of the world. So, for instance, there have been family clusters in descriptions of cases and transmission in the African continent, but that's not what we're seeing here in the United States.
Thank you, Dr. Spacek. Dr. Livernice, how do I know if it's monkeypox or another skin disease?
So this is a great and a difficult question. A lot of skin rashes can look like other things. And so I think what I would say generally is you could look at a rash and have a higher or lower suspicion as to whether it's monkeypox, but not make a definitive diagnosis. And how would we do that? We look to see if somebody has a risk factor for monkeypox. And Dr. Spacek actually suggested some of those. Having close contact with somebody who has skin lesions or has known monkeypox. Contact perhaps with an animal, if you're in an endemic area like Africa, that could carry monkeypox. Travel to a foreign country where monkeypox exists, and then you have a rash on top of it. The characteristics of the monkeypox rash, as Dr. Russell mentioned, starts out looking as small bumps, perhaps bug bites, but these evolve over time. They become firm, kind of rubbery and larger, and eventually form pustules, like a pus-filled blister, so to speak, and eventually break and form a ulcer, and then they scab. And that's the pattern. And oftentimes you'll make the diagnosis in the absence of testing by the way the rash progresses rather than the way it looks at any one moment in time. And so I would say I don't think any layperson can look at it and know they have monkeypox. I think a clinician could look at it and have a high suspicion of it. But even with that, definitive testing is really the way to go when you have a high suspicion. Most of the people who I've come across who think they have monkeypox, we generally can look at and realize it's something else, and they come from a low risk group.
Thank you, Dr. Livernice. For Dr. Russell, is there treatment for monkeypox?
To be completely clear, there's not a FDA approved monkeypox treatment. But smallpox has certainly been a kind of threat on this planet for forever and ever. And there are a handful of medicines that have been FDA approved for smallpox that have an emergent crossover use that someone could use in an emergent situation, that a clinician could contact the CDC to release some of these medicines. But really, this is going to be for a very select group of people. And, as we saw with COVID, a novel infection is really going to be most drawn to our sickest, weakest, most infirmed members of our community. So the people who are more immunocompromised might be someone who might be treated. Someone who is hospitalized might be treated. But the vast, vast majority of the 18,000 people in the United States, it was 3 to 4 weeks of probably a little discomfort, a little annoyance, but probably not progression to a point that actually needed some treatment with some medicines that still have an emergency use authorization for it.
Thank you, Dr. Russell. Dr. Spacek, so we talked about treatment for monkeypox. Is there a vaccine for monkeypox? And if there is, who should get vaccinated? When, where, and how can they be vaccinated?
So I'm very happy to share that there is a vaccination for monkeypox. It was FDA approved in 2019. And in fact, it's been something that we have used in medicine for some time. This vaccine that we're using is a safe vaccine. It's been used in patients who are immune compromised, and we're confident about the safety of this vaccine. This vaccine is effective. So the idea that we can get this vaccine out to people who, at this point in time, have either been a contact, a recognized or a proven contact to monkeypox, which is what the CDC is calling post-exposure prophylaxis. So patients who have had a recognized or known contact to monkeypox could come in and get vaccinated in a post-exposure prophylaxis scenario, or if they have post-exposure prophylaxis plus, which is called PEP++. So they don't have to have a confirmed contact, but they could have had a contact that is presumptive or at risk for having had monkeypox, or they've had an anonymous sexual encounter with someone that they're concerned has monkeypox, or they've attended a party where other people have ended up having concerns for monkeypox. So it's a two-tier post-exposure prophylaxis or post-exposure prophylaxis plus. So people who are at risk for contracting monkeypox can have the vaccine. It's called Jynneos. So it's spelled Jynneos. And it's a vaccine that comes in 2 doses, the first dose, and then the second dose is 28 days later. Right now, we can give this vaccine either in the subcutaneous tissue, or we can give it in the dermis. So we have intradermal vaccines like we have given a tuberculosis test in the past, or we can give it in the fatty tissue as a subcutaneous injection. So right now we have available vaccine, and I know people have heard about the splitting of doses. So we were able to take the vaccine that was available from the Strategic National Stockpile and use that in a way that multiplies the number of doses that are available by 5. And that's been something that I know has been recently in the news. So that's really helped us address the scarcity issue around that vaccine. So we have a safe and effective FDA-approved vaccine. We have plenty of it, and it can be given to people who are at risk for having contracted monkeypox. At this point, we know that we can use this vaccine 4 days after a patient has reported the contact and up to 14 days after that contact, and we can expect to have that vaccine do some good. We can expect that vaccine will help reduce some of the symptoms that are caused by this virus. And that's been a very exciting tool that we've been able to use through the assistance of Montgomery County.
Thank you, Dr. Spacek. I'm going to amplify a couple of her. Was there another comment?
Yeah, I actually maybe stepping on your toes, but I thought I would just add to something Dr. Spacek said about this dose splitting concept of using the intradermal vaccine. There's been a lot of concern raised in social media about maybe perhaps underdosing people. This is not a new concept. This has been in existence for decades, that we can give a small dose right under the skin and very effectively vaccinate individuals. So it's not something new. It's known to be safe, and it causes a very good immune response.
Thank you, Dr. Lorraine. That was actually one of the things I was going to amplify. We actually have, even more than what Dr. Lorraine said, there actually was a study done in 2015 looking at this specific vaccine that looked at groups that got it in the subcutaneous area right under the skin, or intradermal within the skin at 1/5 the dose, and found that they had exactly the same immune response. So this is clearly based on scientific data. It's not underdosing at all. It's perfectly safe and produces the equivalent response. Another thing that I wanted to amplify that Dr. Spacek said, she talked about the 4-day and 14-day window that we have to give this vaccine. If we give it less than 4 days, we hope it would actually prevent monkeypox. And if we give it up to 14 days, we can decrease the symptoms. But the converse of that is that someone who actually has monkeypox symptoms would not benefit from the vaccine. So we do not vaccinate that population that already actually has the disease. And the vaccine is available through a number of healthcare providers. Dr. Spacek and Novus has been very, very good in being able to immunize a fairly large number of the population. Montgomery County also has this availability. So people who think they may have had a contact and have concern can contact us at Montgomery County Office of Public Health through our website, which I believe Kelly will probably throw onto the chat, and can schedule, if appropriate, a vaccination for monkeypox. You would be interviewed by one of our infection specialists at that point and determine whether or not that is appropriate for you. But we are able to vaccinate. We have regular openings in clinics, so we do have quite a bit of availability for that. And next question to Dr. Livernice. How long is a person with monkeypox contagious? I actually got that out, I believe, of Dr. Russell a little while ago, but I think that bears repeating.
I would agree with you. This is probably one of the shortest answers you'll get tonight. People are contagious with monkeypox until those skin lesions have dried up and closed. So as long as you have lesions on your skin that are open or have poorly formed scabs on, you're still considered contagious. And that probably goes on in the average person for at least 2 to 3 weeks, perhaps even as long as 4 weeks.
Could I amplify that answer a little bit?
Please do.
Until you have skin lesions, you are not contagious. So yeah. I think for a lot of public health settings, that if someone is coming in someone has been exposed and they're coming in for a vaccine, they are not putting the people who are vaccinating them at any kind of increased risk. So before the skin lesions happen, someone is not necessarily contagious.
Right. Which is a big difference between this and COVID, and something we've all been dealing with. So people are safe really to be around others until those lesions break out, and helps us a lot in terms of contacts and contact tracing.
Thank you both. Dr. Russell, what should an individual do if they believe that they have symptoms or skin lesions?
Well, I mean, I think we've all kind of lived so much in this public health space for the last 3 years, and with regard to kind of new infectious disease, a certain amount of grace and etiquette, I think, is important about this. So I think you should be seen and you should get tested. It's not the worst thing to the place that you're going to be seen and to be tested for the patient to say, I'm worried I might have some monkeypox. So the people who are taking care of that person can use some proper precautions. So we're still all living in a world where we're wearing masks, but we might not be living in a world that we're wearing gloves. We might not be in a world that we're using some other type of protection. So I think that would be helpful. It would also be helpful for that place to know, for that practice to know someone's coming in. Maybe they don't have the swabs available. Maybe they had 2 this morning and they used them up. So if someone is going to come to be seen, it would be nice that they're being seen at a place that actually could do the diagnostic testing that's needed. And so it's a one-stop. So they're not coming to my office and then having to go to an urgent care or the emergency room to get tested. So just, coordinating with the people who are going to be providing your care to see, are they able to provide their care? And can you do some things on the other end to make it a less anxious event for the healthcare workers? And I think, and it's great that we're doing things like this, but I think there are still a lot of people out there who are anxious, a lot more anxious than they need to be about that. And I think you can assuage that with just a little grace.
Very good. Thank you, Dr. Russell. So, Dr. Spacek, we're talking about how people get monkeypox, but can pets get monkeypox as well?
Yes. The orthopox viruses infect mammals. And so we have seen one documented case of a dog in France, is what I was reading in the paper. The idea that if your pet is a prairie dog, that would really fit into that 2003 outbreak. I think the idea of exotic pets is really one of the first very memorable examples of monkeypox presence in the United States. So certainly the answer is, depending on what kind of pet you have, you might be more or less concerned. With respect to the pet truly having the opportunity to get infected, I think that would speak to the issue of co-sleeping or bed sharing, that at this point, since we haven't seen a lot of concerns or outbreaks or documented cases involving pets, I think it's really kind of theoretical at this point. Our pets being mammals, if they're dogs, that's more concerning. But if we've only seen one documented case, I think that the risk is relatively low. But that said, if there is a person with monkeypox and they would choose not to have their pet sleep with them in the bed, I think that would be the best way to approach the situation, because there certainly is the possibility that a pet could get monkeypox.
Thank you, Dr. Spacek. Dr. Livernice, how can I protect myself and others against monkeypox? We kind of touched on this a little bit.
Yeah, we have, and without being flippant, number one would be to avoid coming in contact with people who have monkeypox. That's kind of obvious to us, but I think on a more practical level, I think you have to be very conscious at this point in time about who you have intimate contact with. And if you're in a monogamous relationship with somebody and you know where they've been and what they've done, I don't think you need to take other precautions. But if you're somebody who has multiple sexual partners or is having anonymous sex or is involved in other activities, maybe not sexually based, where there's skin-to-skin contact. If you go to a rave where people are not wearing clothes and you have close skin-to-skin contact, those are risk factors for it. And I think you just need to think about the activities you're doing and try to decrease your exposure at this point in time. This is still, in the sum of things, a rare disease in the United States. Out of over 300 million people, we've seen 18,000 cases. And so for most people with routine activities, monkeypox should not be an issue. But there are certain pockets that we should be aware of. And I think thinking about that is an important part of protecting yourself.
Can I add, just interject?
Please do.
Turn on the lights. With our students, I don't know,
Yeah.
With our students going back to college, I just dropped off my son. I think that it's a good bit of advice to say turn on the lights, because if you are engaging in close, intimate, or physical contact and you turn on the lights, it's going to give you the opportunity to look and see if someone has lesions.
Practical. Thank you, Dr. Russell. I'm sorry, that was Dr. Livernice. Dr. Russell, the next question.
Sure.
What are school-based recommendations to mitigate the spread? And also, once there are cases in a school, what are the possible next steps?
So, I think in certain ways, if someone has monkeypox, they should be staying home for the 3 to 4 weeks until their lesions have healed up. And one of the things I think we think in certain ways, this is a novel question, but if you think about skin to skin contact and you think about high school kids, wrestlers, there are clear recommendations in PIAA for us in Pennsylvania and NCAA of certain viral skin disorders that you are not allowed to wrestle with. There's some variations on herpes, on some different herpes infections, etc., but impetigo and a lot bacterial infection. So there are things that would preclude us in the heat of doing a competitive sport that I should not be allowed to play, because if I'm a wrestler, by definition, my skin is going to be touching, other people's skin. I personally worry more about the colleges and the dormitory type things than I necessarily do elementary, junior high school things. But the kids who are off at college and are exploring all kinds of freedom, often involved with kind of alcohol and sometimes not the greatest of decision making. That's the thing that you kind of worry about. And I think that we want to make sure that we are not trying to be so prescriptive and have so much blinders on to think that it only happens in one population in the United States. It conceivably happens anyone whose skin touches someone else's skin. And I don't think that we should be so parochial to say this isn't something that they should be thinking about at any college where you have kind of young people with freedom and often not always the best decision making.
Thank you, Dr. Russell. And a couple additional comments with that. So because intimate contact is often associated with potential transmission, there is a little bit of a difference, as Dr. Russell was alluding to, between, say, the college population and then the K through 12 population. The incidence thus far in young people and in children particularly is very, very low. It's not zero, but it's much, much less likely overall. We still should be aware of it. We should still prepare for it. So schools are developing their plans to deal with it. There are a couple of things that are commonly asked in the schools. One is, and we kind of touched on this earlier, should people who have been exposed to monkeypox be excluded? Should they be quarantined? And the answer is no. If they do not have the actual skin lesions, they cannot transmit the virus. And another thing that we kind of talked about with the vaccination is, should other people be vaccinated preventatively? Should we have a mass immunization program similar to what we've done with COVID? And right now the answer to that is no as well. We are using the pre-selected population, those who are at highest risk, either those who have direct contact or who are engaging in behaviors that put them at higher risk to be vaccinated. So these all form a part of the school response programs. They are aware of the potential transmission through fomites. These are things that come in contact with someone who might have lesions. And they have their enhanced cleaning protocols that they actually developed for COVID as well. Not that it's necessary for COVID, as it turns out, but this is also a part of the school response. So we're preparing for it. We're not going to ignore the possibility. Thus far, at least in K through 12, the incidence has been exceedingly low, and we expect it to still stay low. But there is additional concern once you have young adults, particularly in the college group. All right, moving on to Dr. Spacek, which is essentially a question that I was just getting into. Is there a proper procedure for disinfecting fomites or things that have come in contact with those who have skin lesions?
Yes, and I would refer people to the CDC information, because any of the disinfectants or treatments would have certain specifications regarding how it is to be used. And if it needs to dry in order to be effective. Those kinds of details, I think that that's something that you should be aware of based on whatever kind of a disinfectant you're using. What I would emphasize here is that wet cleaning makes more sense than dry, because what we don't want to do is take viral particles and make them airborne. So one of the concerns that I've had is that if you say, for instance, took the sheets of someone because you were, changing the bed sheets, you were changing the linens, that you wouldn't take it and shake it out, because then that would make the potential for those viral particles, those infectious particles, to be airborne. So what you'd rather do is roll up the sheets or have a disposable paper sheets, like for instance in an exam room, so that you could just roll that up and throw that away, as opposed to having people handle or have the potential for making something dry be airborne. So that wet cleaning, I like as a way to remember the best way to approach it. And whatever the disinfectant is, would be particular to what you have on hand. I don't think there's any different messaging to be made except for hand washing. That we always want to wash hands, soap and water. There's sort of those basic points of hygiene that make sense and that we should keep in mind.
Thank you, Dr. Spacek. And I want to amplify one point that you made very early on. When you are dealing with disinfectants, there's different instructions that come with these disinfectants. And it's actually really, really important to read those instructions. There's something called dwell time, which basically is how long should the surface stay wet to achieve a proper disinfection. So I know a lot of people will be spraying on disinfectants and wiping them off immediately. That doesn't allow for them to be their most effective. So I strongly encourage everyone to read the instructions. Dr. Livernice, if I had monkeypox in the past, can I get it again?
Very timely question. I think first we have to say that we're still learning a lot about monkeypox as this outbreak goes on, but certainly experience in Africa, information we have from the CDC, and as well as information we can infer from smallpox suggests that if you have you're infected with monkeypox, you actually do develop immunity. How long that immunity lasts I don't think is really clear yet. But I think there is immunity after an infection, and my guess is it certainly is going to last for months, if not years. But I'd love to hear what the other people on the panel think about that thought.
I think one of the questions comes up. I think at least some of us on the panel probably were vaccinated with smallpox, which ended in 1972, and a lot of the studies that looked at monkeypox, some in the early 2000s looked at population of healthcare workers who had all been vaccinated against smallpox, and the transmission rate was very low. So I clearly think that there's some pretty good information if we have got the smallpox vaccine once upon a time, we're protected. And a great side study, someone did a study of the smallpox vaccine from people who got it long ago and found 88 years later it still had really good protection. So that is a product tried and true, really built to last. So I think we're going to have some protection, but again, I don't think there's enough monkeypox information. I think there's good smallpox information.
Yeah, I think that's a good point to make, that there's a distinction between what we know from having studied smallpox as opposed to what we know from having studied monkeypox. And I think one of the ideas that warrants a little conversation is that because of how we encountered COVID as a novel pathogen, and we saw the difficulty that we faced as a population, that's something that is different from monkeypox, in that this is not, say, a novel pathogen. We do have elements of recognition within our immunologic repertoire if we have been vaccinated against smallpox. And I think that one of the reasons that we're seeing this now is that there has been a waning immunity as a population, so that the more and more people that are growing up without having had smallpox vaccine has left us with enough people who are able to acquire monkeypox. And so I think that as a population, what we're seeing is not a novel pathogen, but a pathogen that, the virus that's had an opportunity to infect people, because there are enough people who don't have that knowledge, their immunologic recognition of that virus. So back to the issue of how long it would last. I'm in the corner of the T cell. I'm in the corner of our immunologic memories as individuals recognizing something. And although you may not get it, you may not get it and be so sick with it. That's, to me, a big difference. And I think that's something that we can create when we vaccinate people, that if we have the opportunity to vaccinate, we can have a lesser degree of suffering and disease. And so one of the concerns that I have about the people who do have monkeypox is that it can be very painful. And so if one of the manifestations may be a very painful sore throat that prevents people from being able to take in fluids or eat. And in the instances when I've referred people to hospital, it's for IV fluids, because they've been unable to keep up with the amount of food or drink over the period of time that they're having these lesions. And I've also found that it's been difficult to control some of the pain around these lesions, to the degree that we are using a very short course of narcotics in order to manage the discomfort.
Thank you, Dr. Lorraine and panel. And Dr. Russell, to kind of tie this all together and look at current events, is this the COVID-19 pandemic all over again?
It isn't, right? So we're talking about something that is much more transmissible with contact. When they've looked at older studies with monkeypox and they looked at kind of transmission to household members, it was still under 10%. So this is not something that's so transmissible. But I'm a little bit of a historian, and I kind of love the history of epidemics. And if you look at epidemics that have happened in the United States over time, all of them have gotten worse because someone recognized something and someone said, well, it's just happening to those people over there. We don't need to care about it. So I see a little bit of that, right? I think when we have a public health thing, we need to respond as a public health community and as a community, just to respond to make the fire go out. And when our neighbor's house is on fire, we need to grab a bucket.
Thank you, Dr. Russell, and that gives us a perfect lead into our final submitted question. We've talked about, Dr. Spacek, we've talked about the at-risk population currently, and we talked about at-risk behaviors. And you had mentioned particularly the population of men who have sex with men are particularly exposed these days. But can we talk about whether or not other people other than the LGBTQ community are potentially exposed and should have concern?
Yeah, so I think that that's a difficult question on some level, because the virus doesn't care. The virus is an equal opportunity pathogen, an equal opportunity moment. And I think that it makes sense to be able to help people understand that this is not a casual moment. You're not going to get it on the bus unless you're having close, intimate physical contact on the bus. So these moments of, people who are not engaging in behaviors that then invite that infection to occur don't have to be worried about something that is not going to happen given their behaviors. The fact that it can be transmitted in certain situations, and at this point we're seeing in men who have sex with men, is not a judgment. I mean, this is an observation. But I think that the issue to keep in mind is that if people have an infection that they're worried about, that, we're all in the practice of addressing these concerns. It's important to have a trusting relationship, because you can have better outcomes when you're a physician or a provider and you're helping a patient who's giving you as much information as they are willing to, so that you can give them the direction and help that they need. So I think that trying to kind of unpack what can be stigmatizing is really important, and recognizing that, you know, viruses are equal opportunity, and the idea that what we want to do is be able to help people. And in order to do that, we need as much information as we can gather so that we can make good decisions based on the epidemiology, you know, the detail of the context of what has happened in someone's life, so that we give them the best guidance. And I think that that's something that is very important to anybody who's in the practice of providing care.
Thank you, Dr. Spacek. So at this point, we have come to the end of our pre-submitted questions, and we do have a few that have been submitted in the Q&A. And let's see, this one I believe is a very good segue for what Dr. Spacek was just talking about, but I'm going to toss it over to Dr. Livernice. Do we have to have concern about using public restrooms in monkeypox?
Oh, there you go. So I was on mute. Interesting question. I think the answer to that probably is no. That being said, I think if you're going to use a public toilet that is visibly soiled, that's a bad idea. You're going to come in contact with human body fluids, which could potentially transmit disease. But I think even in that situation, I would think the risk is still going to be very low.
Thank you, Dr. Livernice. This one I think I will give to Dr. Russell. So if someone wants or needs to be tested for monkeypox, where would you recommend that they go?
Well, I think so there's the commercial labs in our area. So 2 of the large commercial labs are able to do testing. A lot of the testing material probably should be available in most primary care offices, certainly in the urgent care, certainly in the emergency rooms. Again, it doesn't hurt if someone wants to be tested to call ahead. So just so you're not disappointed and people are scrambling and people can figure out the right thing to do. So you might need to drive a couple more miles to get to a place to get properly tested, but the trip would probably be more worth the while. If you don't have skin lesions, you don't need to be tested.
Thank you. I was actually going to amplify that last point there. So this is not something that we can do, say, a blood test to see if it's being carried. It is purely after the development of skin lesions. Thank you, Dr. Russell.
I would emphasize that and say, if you don't have skin lesions, it's not that you don't need to be tested. You can't be tested. We don't have a way to actually test you in the absence of those skin lesions.
Thank you. And let's see, along those lines, Dr. Spacek, can you carry the monkeypox disease, but they wrote not have it, or not have overt symptoms? Can you carry the virus but not have overt symptoms?
No, and that I think is one of the key features of, say, the eradication of smallpox. Because it's something that we can see, these nodules, these pustules, these obvious lesions, this is something that is not carried, or it's not asymptomatic. So the important understanding here is that in order to have this infection, it's a symptomatic, expressed, visualizable rash that is recognizable and classic. So that's something that defines this illness.
Thank you, Dr. Spacek. And with that, we have come to the end of our submitted questions for this evening. And it looks like we're actually pretty well on schedule. So if there are no further questions from the audience, what I'd like to do is turn it over to each of our panelists for some closing comments. And we'll start with Dr. Russell. What would you care to say to close us out?
So the world has gotten smaller, right? And if you look at all the things that cause infections in humans, 80% of them started in animals. And as the world gets smaller, as we bump up against different species, there are going to be new and emerging infections that are going to happen. And this is our new normal. And flu, started with animals, right? So many things that are in our common parlance started with animals. So and Ebola or cholera, once upon a time, things people never thought that they would leave where they came from, but transportation caught up with that. So this is not the last time that we'll be in a forum like this talking about a new infection and how we're going to approach it. And I think we just need to kind of be calm about things, get information from the right sources, and be a good citizen.
Thank you, Dr. Russell. Dr. Livernice.
Yeah, I would just like to say, I think if you're someone who is at risk, please pay attention to your behavior. If you've been exposed, please investigate vaccination. But having said that, and pushing vaccination, I'd like to point out that we're coming on flu season. We're still in the middle of a COVID outbreak, and vaccination against both of those viruses actually will carry much more impact than a monkeypox virus vaccination will at this point in time. So just a shout out to flu and COVID immunization. Thanks.
Thank you, Dr. Livernice. And I'll add to that we are expecting flu vaccine to be out and about imminently. And I encourage everyone to get vaccinated for flu. We are also seeing the approval of the bivalent COVID vaccine. And that is something else that you should be looking at in terms of whether or not it's appropriate for you. For our final comments, Dr. Spacek.
So thank you so much for this opportunity. I would say two things. One is that in the vaccine clinics that I've been a part of, the people who have been vaccinated have been very, very grateful to have had the opportunity to get vaccinated. So I think in this setting, it's easy to be very pro-vaccine, but I would say that in general, the recognition that this is a tool that can prevent or make a disease not as bad is recognized. And I just want to put that out there because I think we're all very pro that. And I think that the patients and the people who've gotten vaccinated share that with us. The other thing I would say is that in the setting of diagnosing monkeypox, there is great utility to checking for other sexually transmitted infections, especially if we're talking about potential for sexual transmission of monkeypox. So that what we've seen is perhaps syphilis lesions that potentially could resemble monkeypox in that it is a rash, or herpes, other sexually transmitted or transmissible infections that as providers, we keep in mind, and we can do that additional testing for other sexually transmitted infections in the setting of a concern for monkeypox.
Thank you, Dr. Spacek. That's a very, very important point for our providers who are on the line to be aware of. Within the county clinics, we've also discussed that as well. And we do have plans to do general screenings when we see those who are potentially infected with monkeypox. And we are also, for those who are coming in for vaccination for monkeypox, we're offering the hepatitis A vaccine as well. So we kind of cover two things at the same time. And with that, we've reached the end of our forum for this evening. I'd like to thank each of our panelists for participating. I think we've gotten a fantastic amount of really great, valuable, and trustworthy information. We're very, very lucky to have clinicians like these in our community, and especially those that are willing to come and share this information with us. As we found from the beginning of this pandemic, the antidote to fear is information. And that's what we hope to do. We hope to get this information across to people so that they don't have so much to fear. And that in the final analysis, I encourage everyone to discuss any health questions they may have, whether it's monkeypox, COVID, their regular health care, which should not be left alone during the time of this pandemic, please discuss any of these questions with your trusted healthcare provider. Those are the people that have your best interest in mind and can best explain to you those things which are necessary for your own personal health. Again, I'd like to thank you for being with us this evening, and I hope that you have found this program useful. I would also like to give a special shout out to Beth Till from the Montgomery County Immunization Coalition, who is instrumental in putting these forums together, and without which we would not have been able to come together and share this information with you. A thank you also to Kelly Co-Francisco from Montgomery County Public Affairs, who enables us to have the technical ability to do this. So with that, I'd like to say one final thank you. Stay well and good health to everyone.
Thank you so much. Good night.
Thanks. Good night.